Hello and welcome. My name is Amy Vandenbroek, and I'm the Executive Director for the National POLST Paradigm. As you just heard, this webinar is being recorded, and you will be able to find the recording online at polst.org/webinars or looking at the Technology tab. If you have any questions during the conference, please type a message into the Q&A box. Thank you for attending. This webinar is number 2 in our series that is part of the Technology Consensus Project. This project is to conduct diligence on what is currently being done in our POLST program, to invite vendors to share their solutions, and work with experts in a number of fields of technology, security and privacy, electronic medical records, health information exchanges, registries, legal, patient communications, to identify best practices and provide guidance to help POLST programs effectively harness the promise of technology. There are 3 parts to this. Webinars, we will have a consensus conference, and then we will be putting this information into a white paper. The goals are to develop a thorough and helpful best practices guide for POLST programs to use, to identify technology-related priorities, and then to help align product development that supports the POLST paradigm and our fundamental values. I'm very excited to introduce our guest today. Dana Zeid serves as the Technology Advisor to the National POLST Paradigm. She has worked on POLST registries, interoperability, electronic medical records, and integrating POLST form data with information exchanges. She also serves as the Director of the Oregon POLST Registry. So thank you. Dana?
Thank you very much, Amy. I hope everyone can hear me. Since I can't hear you, I'm going to assume that you can. I'm very grateful to be here today and have the opportunity to talk with you about a topic that is very close to, if not my heart, certainly the last 10 years of my employment, but actually very close to my heart as well. I have been looking at POLST registries and working with the concepts of registries since about 2007, 2008, and to see the change that has happened in just 10 years has been pretty phenomenal. So we don't have a ton of time today, and I'm going to be trying to cover a reasonable amount of information, so I apologize if I'm going too quickly, but what I'm hoping to do or planning to do is putting together a fact sheet based on the webinar today that can go out to anyone who participated or even those who didn't and will be watching later, and will also provide contact information for some of the states whose information I'm going to be covering. I want to start really quickly with a definition of when I'm using the word registry, what it is exactly that I'm talking about. So when I'm talking about a registry, and this is in relationship specifically to POLST today, although I know that registries can collect a lot of other information, a registry securely collects, maintains forms or their content, and allows that information to be updated. Because we all know that POLST is a living document and can certainly be changed upon patient wishes or health status change, or really for any other reason. The other critical part of a registry is that it provides access to forms or the information held within them to a defined audience through one or more mechanisms. And this is critical because you can have a document storage solution, you can have a filing cabinet where absolutely every POLST form that you've ever seen in your institution is put, but how quickly can you get that information out when it's needed most, if a patient is having an emergency or if you need support with healthcare decision making. Some of the mechanisms that we'll discuss today that are being used are call centers, web portals, integrations with electronic medical records, and health information exchanges, which I'm using broadly to describe health information networks, health information organizations, all of the possible data sharing mechanisms that exist between healthcare institutions with data use agreements overseeing what information can be seen and by whom. So who are we going to talk about today? Well, we're going to take a chance take an opportunity to look at, I believe, 8 different states and approaches that they have taken, are taking, or are looking at taking in terms of providing a POLST registry for either their state or for a region. I'm a big fan of organizing alphabetically, and that is the way that I did this, so no one should feel that they're being slighted in any way. I don't know, Woody, if you're on, but West Virginia just happens to come last in the list. So California. California is a pretty big state, as you may or may not know. POLST was legally authorized there in 2008, and the State POLST Task Force is very strong and has 26 local coalitions. It's overall managed by the Coalition for Compassionate Care of California, or CCCC. It is a diverse state, and I don't mean that just in terms of the demographics of the population, but actually in the way that EMS, pre-hospital medicine, and hospital systems, as well as long-term care systems, are highly variable, not just in their practices around POLST, but in their ownership, their electronic medical records, the systems in which they communicate. So obviously that can create some challenges when looking at trying to implement either a regional or statewide registry. So what's happening right now is that under funding from the California Healthcare Foundation in partnership with the Coalition for Compassionate Care, California is currently piloting registry models in 2 separate counties with third-party vendors. One of these counties has a health information exchange. This is San Diego County, and in that system, Stella Technology is doing an integration with San Diego Health Connect, which is the HIE. This system has direct feed input from some institutions, meaning that data entered into an EMR is being taken directly into the registry, and it also has an upload function where individuals can upload a POLST form into the system, and it will be attached to a patient whose information is contained within the health information exchange. In San Diego County, there's already an existing portal for EMS in utilizing the Health Information Exchange, and that is a program called SAFER, which is the S is search. And what was able to be done was to build on that system so that when an EMS provider is seeing a patient, enters the patient demographic information, if the patient exists in the HIE and a POLST form is present, it will be provided to the EMS provider. The second is a community model that's being tested in Contra Costa County. And here a third-party vendor called Vinca has built a web portal with cloud storage, allowing users to search for active POLSTs as well as integration with a large EMS chart system or patient care record. This is powerful because, again, as demographic information can be entered, a POLST can be readily accessible without a large modification in workflow. Vinca also has systems that allow electronic completion of POLST forms, but not all of the institutions within that county are using that system. So it's an idea to be able to see a number of different mechanisms of how information can get into the registry as well as how it can get out. In the HIE model, people would be logged into their HIE. POLST would be an available option within a patient search. In the community model, providers would be logging into a web portal and entering in some demographic information and being able to then see a POLST for a patient who they are treating. Both go through a level of attestation, which is really quite important because you really need to know who has access to the information that's being included in a registry. And so through the HIE model, if someone is authorized to be in the HIE, they're authorized to see the information. For EMR integrated web portal systems like the Vinca model, if a person has rights at the institution from which they're logging in, those are passed along and those rights are then provided to the system so that a stranger, for example, can't just sort of walk in and see your information. So, moving to Idaho, the Idaho Healthcare Directive Registry started receiving forms actually back in January 2007, one of the earliest healthcare directive registries. It's housed in the Secretary of State's office and to date has over 30,000 registrants. It's a standalone self-built form repository, and it holds copies of POST forms, as they're called in Idaho, as well as combined living will and power of attorney documents. This is a self-submit registry, which means that individuals send or bring in documents, as well as attorneys or other legally authorized representatives who can submit to the registry. Upon the submission and registration, registrants get copies of their information as well as a wallet card as demonstrated on this slide. So forms are then accessed through a web-based portal using codes from the wallet card. Another mechanism is during business office hours to call the Secretary of State's office and the information can be generated. The next state that we'll be looking at is New York. New York has been active in both POLST or POLST as well as registry efforts for a number of years. Their current POLST system went live with its web portal in 2010 with full use in 2011 due to some changes in public health law. It's a web-based system and includes a mobile application. Forms can be electronically completed, printed, stored in either an integrated EMR structure, meaning that a person working in an electronic medical record will have direct access into the system without even the feeling of having left their EMR, and again with their rights and identification information being passed along as well. And then if that document that's been created electronically is completed through the POLST system, it is automatically stored within the repository or registry part of POLST. Of note, while originally an idea was for POLST system to connect to regional health information organizations, in fact, it's sort of been turned around because POLST was able to move forward before the RIOs were able to do what was needed to be done, and now RIOs actually connect to the POLST system. And as I mentioned before, users are registered by their participating health systems and vetted that way. The POLST system currently has over 25,000 users. It's integrated with every major EMR vendor for hospitals, skilled nursing facilities, and the New York nursing home EMR. It allows real-time querying with single sign-on as well as an API, which means that there's essentially no change in workflow because anytime a POLST is available, it will be noted and delivered to the user based on the information that has been simply entered into the RIO or the EMR. Other querying systems allow connectivity with the regional health information organizations, including bidirectional capability, meaning that if an institution completes an POLST through the system, it is instantly available to anyone else who is able to query the system. Sorry, I was getting caught up in some Q&A. I've got to be careful over there. Of note, the New York POLST system is funded by Excellus Blue Cross Blue Shield, and healthcare professionals are not charged for its use. Oregon, which I'm sorry the font is smaller, I just know a lot more about the Oregon system. So we began statewide operations in 2009 through the passage of House Bill 2009, which implemented and funded the registry as a statewide system. It also mandated submission of completed POLST forms unless a patient specifically opts out. We are a standalone, secure, web-based repository. We were developed as a backup for emergency providers when the form was not immediately available. We receive forms via fax, e-fax, mail, and electronically, a lot more transitioning to electronic transmission over time. We initially operated with only a 24/7 call center, which allowed emergency access to form orders to EMS, emergency departments, and acute care units. But in the last 2 years, we have created additional mechanisms for access through integration with electronic medical records and also connectivity with a statewide health information exchange that provides immediate delivery upon emergency department registration. So this mirrors a little bit of how the New York system has that API where there's real-time querying of the system. We also handle a large number of non-urgent requests for POLST forms through our business office, and that's available during our work hours, Monday through Thursday, 7:30 to 4:30. And you might wonder, what is a non-urgent POLST form request? Actually, I realize that not everybody thinks about those when they're generating a registry. The idea of a registry is often for emergent use. But we have discovered over time that there's actually a lot of use for non-urgent requests coming either from clinics, facilities, even individuals who are held to a little bit of a higher burden of proving the relationships that they have with the registrant, either through providing a treatment cover sheet or documentation of legal power of attorney or other legal authority. But what we've seen is, for example, a skilled nursing facility contacting us with a list of patients and saying, which of our patients already have a registered POLST? What is their POLST registry ID? And we think that that can really help support facility operations, and they can then receive a copy without having to go through another POLST, especially if a patient's status has not changed. It also can be a starting point for a new conversation if a POLST form has already been completed. So as I said, we've been live since December of 2009, and to date we have just about 435,000 forms for more than 265,000 registrants, and we receive between 5,000 and 6,000 forms a month. To date, we've received 10,000 emergency calls and about 500 to 600 calls per month to our registry office, and about half of those are usually form requests. We send out information that includes a registry ID number as well as the patient's name, and have changed training for EMS providers to look for this magnet if they cannot locate the bright pink form that they're more used to seeing. Okay, Utah. Well, Utah POLST was legally authorized in 2002 through a health facility licensing program. And there was a lot of work and excitement led primarily by the Committee on Aging that ended up in receiving a federal health IT grant, a Beacon Community Grant, in 2010 with the intent of developing a registry system. There was a registry system that was developed. It was web-based, and unfortunately, the grant expired in 2014, and with no further funds, the registry ceased operations. The good news is that there is a new POLST Registry Committee working together for about the last year with the idea of utilizing the Utah Health Information Network, or UHIN, to identify POLST forms using what's called a record locator system. So instead of having one joint repository where all forms are sent, the idea there is that any place that a POLST form lives, it will be identified at that institution or at that organization. And when a patient is queried, that patient is queried throughout all of those systems, and if there is a POLST flag, so to speak, the POLST will be provided and that information would be able to be shared. So it's a little bit of a different approach than a single standalone repository of forms, but if you have broad utilization of a health information network, then it can bring more of that real-time focus. So this is what's been going on in Utah over the last year. In Virginia, there's a lot of excitement and enthusiasm around registries. However, that has not always made its way into funding, which continues to be a challenge for a number of locations. So Virginia does not have an active registry for POLST. They do have an active advanced directive registry. There are plans under consideration, which include a standalone hospice as the administrative home of the registry, which, as I'm sure you would understand, would require coordination with EMS and the Department of Health in some pretty tightly integrated ways. While there have been multiple grants and other financial requests, as I mentioned, they have not yielded the budget that a registry would need, and they continue to work with their Department of Health. So we will be eager to track changes in Virginia over the upcoming year. West Virginia. Pardon me. So the Center for West Virginia End-of-Life Care, run by Dr. Dr. Alvin Moss, was established and funded by the Department of Health and Human Resources in 2002. It was in 2009 that the West Virginia eDirective Registry was conceived and funded by the state. The state continued that funding through 2018. However, that funding was lost, and now the eDirective Registry is funded by the West Virginia University Health Science Center with the hope that state-level funding will come about again. The West Virginia eDirective Registry has been around for a long time. It serves as an opt-in form system as opposed to an opt-out like Oregon. Forms are submitted by clinics, hospitals, long-term care, nursing home, individuals, elder care, attorneys, other legally authorized representatives, and it has more than 80,000 registrants. Now, I do want to note that the eDirective Registry takes additional advanced care planning forms as well as POLST, but to date they have over 8,000 POLST forms. There had been connectivity to the West Virginia Health Information Network and CRISP, which is another shared data service for patients that was 24/7 immediately available with patient searching. However, it's not currently functional, and they are working to restore that access. So right now, users can call for POLST form requests during business hours. So that was a very quick look through the 8 states with varying implementation of registries. So I wanted to briefly go into some national POLST guidelines around registries that have come together over time. And I'm not going to read all of these because everyone will have the form, but we've talked a little about this. What is a registry? It has form entry. It has updates. You can search it. You have a sense of how many POLST forms that exist are coming into the registry. You have a unique identifier of some kind. You have a mechanism that allows a form to be updated or voided. And then I'd also strongly recommend a mechanism to identify a deceased person's forms, archive them, and remove them from being searchable. There also is a lot of importance around access to forms. Like I mentioned, if you have a big drawer with all of your forms in them, but you can't go through them in the time that you need for an acute care system or EMS, it's virtually impossible to provide that information at the time of a crisis. I think it's also important for non-urgent access. As I mentioned, it can save a lot of time and duplication of POLST form orders. You need to have security. Security. You have to think about that in every aspect of a registry because you, I believe, have to make sure that you're protecting the information from unauthorized access. And you have to have a mechanism that assures the correct match of the patient and the form so that you're not providing the wrong information. That can be done through sensitivity and specificity testing. There's a number of patient algorithm match algorithms that are available for purchase or to work with vendors. And it becomes increasingly critical because the last thing you want to do is give end-of-life care information that would change the course of care for a patient who is not, in fact, the patient's orders that you're looking at. And again, of course, you need to make sure that people can access the information that is available. Helpful things, quality assurance and research, if it can be done. You can actually see a lot of information about POLST forms when you have a registry that otherwise was unable to be seen when POLST forms are just being completed and handed to a patient. So being able to look at those and either support your POLST program if your registry is not part of it, or to support your POLST program for education, those are very helpful. Initial and ongoing education. The education piece will never go away. You always have to think about both users and the audience and also form senders. And you want to make sure that you have appropriate and updated information, frequently asked questions, videos of how to utilize the system. And specifically for EMS, you want to be working with protocol development so that there's a recognized mechanism for EMS to access a registry. Again, legal and security privacy considerations. HIPAA compliance is the minimum that you have to be thinking of. So this is data security, user verification, truly defining who is authorized to submit and sign forms, and having mechanisms in place at the registry to identify forms that aren't valid in that regard. Definitely understanding any state-specific requirements that you have, because if you're going to be accepting POLST forms from, for example, bordering states, you need to know what makes a form valid or not. And then basically all standard consideration of medical legal concerns for risk management. So that would mean disaster recovery planning, downtime planning, and knowing who you would report any type of breach information to. Finally, there's some things that I get asked a lot about registries. People get excited, they're starting with a POLST program and they say, let's do a registry. And I always kind of back it up a little bit and try to remind people that it's not always when a registry is needed, but if a registry is needed. Without engagement of people, without widespread infiltration and education on POLST, you're going to end up with a registry that either has invalid or very few POLST documents, and if it's not of use to anyone, if somebody calls or contacts or searches your registry and is never able to find a match for a patient, especially if they know that patient has a POLST form, they're unlikely to continue using it. So it becomes very important to have collaboration, to have oversight, to have advisement, to have public-private partnerships, to have legislative advocacy if you can, and to really think about registry ownership. Where is the registry going to be housed? How will the data be used? Who is in charge for authorization? And who does it come down to for data security, privacy, and long-term sustainability and funding? You need to be careful of content that goes into the registry. It needs to be based on need, and I would highly encourage you to consider scalability. That is the ability of your registry to grow larger and work in different ways, because your content is what's going to help define the way that your system works, who your users are, and who your audience is. And as I mentioned before, education and outreach, it doesn't ever go away. You don't train people on POLST once. You don't train people on a POLST registry once. It's always making sure that information is available. Again, being able to use data to guide decision-making can be a benefit of a registry, but sustainability continues to be one of the things I hear the most about in terms of concerns. And I just encourage people to consider grant mechanisms that maybe they haven't, that looking at leveraging costs through public-private partnerships, and finally, looking for existing resources to piggyback on. So if there's already an EMS connectivity to a health information exchange, maybe there's a way that that can be connected into a POLST registry without having to reinvent the wheel. So trying to kind of think in those terms. So I think I made it in with 1 minute to spare. So I want to thank you very much. And it looks like we do have one or two questions. Does Idaho charge for the use of their repository? No, they do not. Okay, anything else? I know that was a lot of information kind of packed together, so I'm hopeful that it yielded a basic understanding of the variety of approaches that are being utilized. One thing I can say is that there are a number of vendors who are now working in this arena, which is very different from when most of us started either with POLST or with Registries. So for more information about those or about any of the states that I described here, I encourage you to go to polst.org/technology. And one of the things you will find there is a registry matrix that describes pretty current and recent information about states with registries, as well as contact information. And again, I will work through Amy and the national group to send out a fact sheet that covers the information that I described today.
Yes, thank you, Dana. And this webinar will be posted by the end of the week on our website for this conference, which is, or for this project, which is polst.org/tech-consensus. That's where we have all of our webinars related to this series, and we'll also post the fact sheet there, so you'll have an opportunity to listen to this again at your leisure. And if you have any questions, certainly feel free to contact us at admin@polst.org. So thank you, Dana, and thank you everyone else for attending. We're trying to stick with a 30-minute timing, so we appreciate your attention.